Thank you everyone for joining us this morning for our investment and payment work group meeting this month. Again, my name is Margareta Brandt. I'm the Assistant Deputy Director for Health System Performance here at the Office of Healthcare Affordability. And I use she, her pronouns. And this is our 10th meeting focused on behavioral health investment of our investment and payment work group. And as we always do, if you could please introduce yourself in the chat with your name and your organization, that would be wonderful. And I did want to note that we heard from several investment and payment work group members that they would be out of the office, unable to join today. I think it's spring break for lots of folks, so we might have a little bit light attendance from investment and payment work group members, so just an FYI. So moving into
Margareta,
yeah.
It says I'm not a participant of the chat. I'm not sure if that's just me and a weird issue on my end. I don't know if any of the other.
We can try to update your access to the chat.
Okay, I'll just hang on and see if I get re-added versus leave and come back or something like that.
Okay, so moving to our agenda. So as we always do, we'll start with some updates and context for the rest of our agenda. So we will start with a review of last month's meeting, of course, a review of statute, and we'll spend some time discussing important considerations for the behavioral health investment benchmark. And then next, we'll look at the remaining issues concerning the proposed methodology for measuring non-claims behavioral health spending. And then following that, we'll look at the claims-based methodology again, specifically the code set that OHCA is proposing to use to define behavioral health claims, which will be shared with work group members and this group for feedback following this meeting. So we're aiming to share the behavioral health claims-based code set with you all this week. And then before we wrap up, we will preview upcoming topics for our next meeting. And then just as a reminder, as we always do, just a note about our work meeting format, and then just an emphasis that as if you are putting comments and questions in the chat, we aim to get to all of those and use those to in our discussion. But if we aren't able to get to them, we still appreciate the comments and in the chat, and we use those as we move forward. And if you can, it would be great to include your name in your chat so folks are tracking who's chatting. And then, as we always do, a reminder of our work group members. And then, since we haven't looked at OHCA's statute for probably a few meetings, we wanted to just, as a reminder for today's discussion, kind of emphasize our requirements under statute. So OHCA is required to measure and promote a sustained system-wide investment in behavioral health, to measure the % of total healthcare expenditures that go to behavioral health, and to set spending benchmarks. So this is really the kind of the guiding principles in statute that we are following, and that guides all of our work in the work group. And then, in statute, there are several areas where it emphasizes that our work is intended to promote improved outcomes for behavioral health through integrating primary care and behavioral health, implementing innovations that integrate behavioral health with the broader social and public health services, promoting alternative payment models and telehealth, and other solutions that could transform behavioral health care or care more generally and reduce disparities. And then moving into our logic model, another kind of refresher that we wanted to share at the beginning of today's meeting is this is the logic model that we developed early on in our process of focusing on behavioral health in the work group, and it illustrates how we see OHCA's work contributing to improved behavioral health outcomes. So through measurement and reporting and focused benchmark, OHCA can support other stakeholder actions to improve behavioral health care, such as building infrastructure, promoting integration, and reducing health disparities. And these improvements contribute to achieving the system-wide behavioral health goals that are listed on the left side of the model, which in turn can activate further stakeholder action to improve and strengthen behavioral health. And then moving again to a reminder of our scope of measurement, just, this is another piece that's really guiding for our work is what can we measure and how we are collecting data. So just a reminder that the scope of OHCA's measurement efforts does not encompass all possible sources of behavioral health care spending, and this graphic really illustrates that we are focusing on clinical spending, that is behavioral health clinical services paid for by healthcare payers like commercial and Medicare Advantage health plans, and public payers such as Medi-Cal. And this scope is directly related to the data that OHCA will be receiving and will not capture the important upstream population-based services and wellness interventions and other preventive services that we've discussed a lot and how important they are in this work group, but they're not necessarily captured in the data that the payers submit. So we recognize that this is a limited view of behavioral health spending and understands the need to continue to think about how to better capture those other areas of spending. And we continue to note all of the work group suggestions by the work group members and other stakeholders, and are exploring ways to supplement this clinical spending that we will be capturing. And in our next slide, we wanted to just do a little wrap up of the feedback that and discussion that we had in our March meeting. So we had some really good discussion of measurement and benchmark issues. Some of the key points that emerged for that work group members noted the critical importance of preventive behavioral health services and urged us, OHCA, to capture the spending for these services whenever possible. There was support for including services provided by subclinical professionals like peer support specialists and measuring non-claim spending for social care integration. And we also clarified that mobile crisis services are one of the subcategories included in the proposed outpatient community-based services for the focused benchmark. And in a discussion of how to collect the data on spending for behavioral health screening and assessments, there was pretty broad consensus within the group that spending should be collected in each relevant subcategory rather than grouping all of the screening and assessment spending in its own separate category. And then there was some interest expressed in the meeting for measuring and reporting on spending to be compared to the benchmark as per member per month, a per member per month amount rather than the percent of total medical expense. As many of you responded to the survey about this question, we'll talk about this in a bit later in the meeting today. And then also wanted to note that in our advisory committee recently, several members of the OHCA advisory committee also expressed preference for measuring spending as a per member per month amount. So with that summary recap of our March discussion, wanted to take us to kind of the next steps and timeline for our work. The key thing here is we are proposing to extend our work through August. We are, lots of things to talk about, and we also really are working hard to share some behavioral health spending data with you all, and want to make sure that we are able to share that with you all before we really dive into discussions about where to set the behavioral health investment benchmark. So to arrive at the Healthcare Affordability Board, OHCA's board, voting to adopt the Behavioral Health Investment Benchmark in a meeting this August, we are proposing kind of the following approach. So we are proposing that the draft recommendation for the benchmark be released for public comment in June, and that is also when we would bring it to the OHCA Advisory Committee for review. And as I noted, we're also working towards sharing behavioral health spending data with you all, and we hope to be able to share that data with you in May. So to get there, we'll continue discussions in the work group today, and we will also plan to brief the board at its meeting next week about our progress so far. And then in May, we aim to present data on behavioral health spending to you and a benchmark recommendation for discussion, and then share that data with the board as well. And then in June, we would like to the work group to finalize the recommendation, which we'll share with the advisory committee and release for public comment. And then getting to presenting the recommendation and public comments to the board at our July meeting. And of course, we will, take feedback and make revisions along each of these steps as we move forward towards August. So I will pause here just briefly for any questions or comments related to kind of the recap of where we've been so far, kind of what's our context, the recap of our March work group meeting, and this proposed updated timeline. Yes, Beth, go ahead.
Yeah, I appreciate, I'm not looking forward to working on this longer, but I appreciate you trying to move us forward by getting us data. And in preparing for this meeting, I realized that having some actual concrete data would be helpful to a number of the discussions we're going to have today. So, even if I have, I want to play hooky this week, I think it's probably the right call. Thank you.
Thanks, Beth. Any other comments or questions before we jump into one of our first agenda item? Yes, Carrie.
Margaret, I also want to thank you for this timeline. I think, we've been, I know we've had some conversations as well, and just want to make sure, it's good to see that there are touch points where folks, might be able to provide feedback along the way, not just, the advisory committee and the work group, but where there might be some opportunities for other folks listening in to weigh in. So I just really appreciate that. And, the way you've laid it out seems very reasonable to me, and, we want to get this right. So I appreciate the time on this. Thanks.
Thank you, Carrie. I appreciate that. And then do want to emphasize, as Carrie noted, we are happy, the OHCA team is happy to meet with anyone outside of the work group. So if there are folks that you recommend that we meet with to discuss the benchmark and the behavioral health spending definition, we're happy to do that as a way to solicit broader input into this work. So just a reminder that we're always happy to meet outside of the work group to discuss. And I think with that, not seeing any additional hands raised, I will turn it over to Debbie to walk us through our first meaty agenda item focused on the behavioral health investment benchmark considerations.
Great. Thank you, Margaretta, and good morning, everyone. I'm Debbie Lindis, the Healthcare Delivery System Group Manager at OHCA. I use she, her pronoun. And on this slide, which you've seen before, is OHCA's recommendation for how to focus the behavioral health investment benchmark. The benchmark is represented by the inner circle, and it's a subset of overall behavioral health spending measurement. The recommended benchmark includes community-based and outpatient care subcategories of claims-based payments. These subcategories are mobile clinic services and outpatient facility and professional care, which includes primary care and telehealth. The non-claims portion of spend included in the recommended benchmark are amounts allocated to behavioral health in the categories of population health and practice infrastructure payments, performance payments, as well as the outpatient and community-based services portions of capitation payments. So these are the key decisions for setting the benchmark that we've been discussing. The form the benchmark should take, whether it should be incremental, long-term, or both, and the timeline for achieving the benchmark. We'll look at each decision in turn, bringing in the responses from the survey we sent out after our last meeting, and we'll introduce some additional considerations for discussion. So starting with the first decision, a benchmark could encourage payers to increase behavioral health spending to a certain level measured as a percentage of total medical expenses, or TME, or it could frame the benchmark as a per member per month amount. OHCA's statutory mandate suggests a preference for the TME approach. In addition, setting the benchmark based on TME communicates that increased spending on behavioral health care should reallocate the healthcare spending pie rather than contribute to an increase in total spending. And this is also consistent with OHCA's approach to the primary care investment benchmark. In addition, a percent of TME approach may be easier to implement and communicate than a per member per month approach. This is because per member per month spending amounts differ by payer type, such as commercial, Medicare Advantage, and Medi-Cal. And these differences occur due to differences in reimbursement rates for behavioral health services, as well as differences in the populations served by each payer type and their associated total medical expenses. One reason we may want to consider a per member per month approach is that it might better reflect the cost of achieving behavioral health delivery goals. It can guard against the benchmark becoming unnecessarily inflationary if total medical expense increases are higher than we expect. And the per member per month approach is more consistent with how payers typically measure healthcare costs. Rhode Island, which is currently the only state with a behavioral health spending benchmark, bases its benchmark on a change in per member per month spending. So the 17 workgroup members who responded to our survey, and thank you very much to those of you who responded, we really appreciate your input. As you can see here, that showed a preference for the per member per month approach, which is consistent, again, with Rhode Island's benchmark and payers' practices in measuring spending. So our next key decision is whether OHCA should set an annual or biannual improvement benchmark, which specifies the incremental improvement each payer should make over a series of short time periods, or should the benchmark focus more on a statewide goal achieved over a longer time horizon, or should it combine these two concepts? Annual improvement and long-term investment goals offer different benefits. The annual improvement benchmark meets each payer where they are today and recognizes differences across payers and patient populations. It also allows for short-term adjustments as actual spending levels become clearer with submission of data in early years. In contrast, the long-term investment benchmark offers a vision for the future across all payers. It can also reflect current thinking about the right level of spending, as well as the long-term infrastructure needs to reach the benchmark and the budget needed for that infrastructure. A combination of the two approaches would capture the benefits of both and mirror the structure of OHCA's primary care investment benchmark. So in this question, respondents from the work group generally preferred a combination of the incremental and long-term improvement benchmarks, similar to the structure of OHCA's primary care investment benchmark. So the final key decision is related to the timeline. Some considerations to discuss for this are, first, OHCA believes the benchmark should be aggressive in pursuit of the underlying policy goals, and at the same time, it should reflect reasonable expectations of how long it will take to achieve. We may also want to align the benchmark timeline with OHCA's other adopted benchmarks, the spending growth target set for 2029, and the primary care investment and alternative payment model adoption goals for 2034. However, we should also keep in mind that unlike for primary care spending, the baseline for behavioral health spending is quite uncertain. And this might argue for a shorter time horizon and a less aggressive approach in the early years to allow for adjustments as more data become available. So this question was not on the survey, but we are looking forward to hearing your thoughts about it in just a few minutes. And next, I will pass it on to Mary Jo to walk us through some considerations for setting the benchmark.
Thank you, Debbie, and good morning, everyone. All right, so as we've mentioned, alignment with the primary care benchmark can be valuable, and there is some merit in that alignment if it can be done. It would create consistency for data submitters, and it can make the benchmarks simpler for stakeholders and the public to understand. This slide offers a few ways to think about that alignment with the adopted primary care investment benchmark on the right for reference. The benchmarks can align by embedding the same or similar rates of increase in spending. The behavioral health benchmark could incorporate annual improvements, as the primary care benchmark does. Behavioral health benchmark could be expressed as a percentage of total medical expenses, echoing the primary care benchmark. Here is an example of aligning the behavioral health benchmark with the primary care benchmark. A couple of things to note here. This expects or projects a consistent rate of total spending growth. And you'll see there we have the annual incremental improvement, and it has a measurement of total medical expense. The primary care benchmark requires that payers increase primary care spending about 0.5 to 1 percentage point per year. In the first 5 years, this would equate to roughly an increase of 7 to 14% a year. So I just want to stop there for a minute and kind of explain this. So the primary care benchmark requires that payers increase primary care spending 0.5 to 1 percentage point a year as a percent of total medical expense. And so if we were to translate that into a rate of growth, in the first 5 years, that would equate to roughly an increase of 7% to 14% per year in terms of year-over-year increase. This table shows how we might apply that rate of change to outpatient and community-based behavioral health spending with a hypothetical baseline of 3% of total medical expenses. So at a 7% increase per year, behavioral health spend would increase 2 to 3/10 of a percentage point per year as a percent of total medical expense. So if the year-over-year growth in actual spending was about 7%, which is equal to that 0.5% on the primary care side, it would equal an increase of 2 to 3/10 of a percentage point each year in behavioral health spend. As you can see there, the baseline year, 3%, year 1, 3.2%, year 2, 3.4%. All of those 3%, 3.2%, 3.4%, that's all outpatient behavioral health spending as a percent of TME. On the right side of the table, the 14% rate of increase translates to a 4 to 7/10 of a percentage point increase per year. So at the end of 5 years, outpatient behavioral health spending would exceed the baseline by 40% at the lower rate of growth, or at about 92% at the higher rate of growth. And again, not to belabor this, but that 7% per year increase is essentially equal to the lower end, that 0.5% increase on the primary care side, versus the 14%, which is equal to about a 1 percentage point of TME increase on the primary care side. For the focused behavioral health benchmark, the lower rate of increase, that 7% per year, might be more appropriate. This would allow room for increased spending in other behavioral health categories not included in the benchmark. Right. We also should note that there are some real challenges in setting a benchmark for behavioral health investment, which we did not face in developing the primary care benchmark. First, we do not have complete and reliable data on behavioral health investment, particularly at the subcategory level and for certain payer types. So setting a benchmark relative to a baseline is very challenging. Second, there is no track record of how behavioral health benchmarks work in other states. With primary care, the benchmarks for other states were established using useful guides based on the work in other states. With behavioral health, only Rhode Island has an established benchmark, and it is new and therefore untested. For primary care, there was also a sizable amount of empirical evidence and literature about what the so-called right level of spending is for primary care, both in the United States and also internationally. This was also a useful guidepost for setting the primary care benchmark, and we do not have an equivalent consensus regarding behavioral health investment. We want to show you an example of what a per member per month benchmark would look like using Rhode Island as a model. Rhode Island requires payers essentially to double their per member per month spending on community-based behavioral health care for children and adolescents over 3 years. If OHCA were to apply this structure to California, the benchmark would have a hypothetical $10 per member per month increase from $10 at baseline to $20 in 3 years. Specifically, the California baseline data will be collected from commercial and Medicare Advantage payers in 2026 for the 2025 performance year. So what that means is that the year 3 in this example is actually 2028. Next, I want to take some time for discussion so we can hear your thoughts on the key decisions for the benchmark. Do you support the consensus of the survey respondents on the first 2 questions about how to present the benchmark, and whether it should be incremental or long-term? If so, why? How should we consider issues of incomplete data and the absence of good models in thinking about these decisions? And then what are your thoughts about the third question related to timeline, which was not part of the survey? How should we think about aligning the behavioral health benchmark with the primary care benchmark? So I'm going to turn it over to Margaretta for some discussion.
Thank you, Mary Jo. And thank you, Debbie. And yeah, just open it up for discussion from work group members. Welcome anyone to jump in.
A quick kind of gating question. And again, I don't have no clue why some AI feature is making me look like a ghost. It's very strange. I've never had this happen before. So for I understand that for total the percent spend, we don't have a good sense of what targets should be, but I think I'm understanding too, for a PNPM target, the same would still apply. We don't really have good evidence. I think that same logic would apply on both sides, correct?
Yes, I think so. And yeah, Mary Jo and Debbie, please weigh in. But I think at least our thinking and some of the discussion we've had in the work group previously is that we know that the spending is too low in behavioral health,
Right.
or there's much more spending that could come in to in-network behavioral health spending rather than out-of-network self-paid behavioral health spending. So that's part of the consideration for, timeline. Should we start with a shorter timeline? Should we start with, an increase from baseline in a per member per month approach? So those are some of the considerations that we're thinking through. Mary Jo,
Okay.
anything you want
Yeah,
to add?
oh, go ahead. Sorry.
No, I think that's exactly right. And Jeff agree that we just don't really know what the right amount is. And also it would likely
Okay.
differ by population. I think that's another important piece.
Okay. I'm just trying to kind of go through in my mind each of the different considerations and how much each of them pushes us one way or another. And I guess I'm struggling that particular one would push us one way or another in terms of the methodology. Like, I don't feel like it clearly for me pushes us one way or another, at least that consideration in my mind. But I see a lot of other folks with their hands raised, so I'll cede it back.
It looks like Beth, your hand raise is next, and then Robbie, I'll try to unmute you. Go ahead, Beth.
Yeah, this is exactly that question is exactly why I was feeling the lack of any data to inform this discussion. And I will also add, when we get data, depending on what you're looking at, we know that such a small subset of behavioral health is currently in THCE that we're going to have to be, I mean, it's not nothing, but it isn't what it should be. I think that we all agree on that. In terms of the universe, there's both what is already spent on behavioral health and what's an appropriate spend on behavioral health. And I was interested to see that there's not, unlike with primary care, we had very good literature guiding us. We don't seem to have that here. I do think on your first question on percent of TME versus per member per month, given what the law says, we may need to do both. But I think my answer in that case would be to do both, because I think each of them will give us a different picture. And I also, like others, support doing some combination of incremental and long-term improvement. And I think we're going to need on this very particularly, I think we need both the long time frame and the frequent revisiting, like every year or two, to rethink as we get better information. And I hope as things improve over time. Thank you.
Thank you, Beth. Amy, do you want to jump in?
Yeah, I just had a question. So I know there's been discussion that we don't have previous data, but what has been the budget? I mean, there has to have been some numbers in terms of how much we've been spending to budget, right? And I mean, can we get any of? Sorry, my dog's in the background.
Amy, are you thinking about like a portion of a health plan's budget, or
Yeah,
potentially
a health plan? A health plan? I mean, do we have any government, budget for healthcare spending and more specifically behavioral health?
We do not have that data from the health plans, and we have collected that data. So, but we are. And sorry,
our dogs are having it.
Margaretta, would it be helpful for me to share a little bit about? So, Amy, that's a great point. Obviously, there is in the world historical data on how much has been spent on behavioral health, and we're working with a couple of different potential data sources to bring that to this group. And so we hope in the near future to be able to share some of that information with you, but we don't have it available to share with you today.
Okay. Yeah, I'm just thinking of other ways to inform our discussion.
Mhm.
Yeah. Thank you.
Sure. And it looks like we have Parnika.
Hi. Yeah. I just wanted to comment on the fact that I think that when we, with regards to the your first question, I would favor looking at it as a per member per month amount. I think one of the conversations we've had in these meetings is that there's so much of subcategorical investment in behavioral health that often goes just unchecked or unknown. And I think that if we look at a per member per month amount, we'll probably have a better idea of what's going on. I do understand that, like you described if there's a hypothetical baseline of 3%, and if you look over the next 3 years, there is an increase by a certain amount. I think that just reflects that we don't necessarily have a good idea of how much behavioral health spending is happening. So I personally think, as a physician, that it'll be a more realistic amount to look at. Thanks.
Thanks, Parnika. Catherine, did you want to jump in? Oh, Catherine.
Sorry, trying to get all my controls working at the same time, but I I was in the car to get away from my barking dog. I wanted to follow up on what Parnika just said on that first question about per member per month. I understand the argument and the preference for that, and just want to raise an issue about the comparability to the primary care benchmark. Can you say a little bit more about about any risk in not having those two aligned under the percent of TME if we were to go that direction? I worry about separating them because I think there's so much to be gained in this overall process from keeping the alignment between primary care and behavioral health approaches. Thanks.
Margareta, do you want to take that one or you want me to?
Go ahead, Mary Jo.
So I think that's a great point, Catherine. And I think there's a few things to consider there. So one of the nice things about measuring the increase in spend as a percent of total medical expense is that it reflects what we're really trying to do, which is not make the balloon bigger, right? Not make the pie bigger, but change the size of the slices. And so when we measure it as a percent of total medical expense and measure growth as a percent of total medical expense, it sort of tracks with that idea of changing the size of the slices rather than changing how big the pie is. There, that also provides alignment with not only the primary care investment benchmark, but also targets for total healthcare spending growth, which are also in place, right? And so I think that is an important reason to, even if we don't set the benchmark as a percent of total medical expense, to continue to calculate it that way so that we can always have that as a way to measure and track and understand and monitor, even if we set the target as a PMPM. Because there are also, I think, helpful reasons to set the target as a PMPM. It feels more real to some people. It's like, oh, I have a budget of $20 that's going to go to outpatient behavioral health spending. And they can think about, okay, if I have a panel of 2,000 patients and they each have $20, then this is sort of like what we could do with that total amount of money. And I think that feels more tangible, particularly to providers and healthcare administrators and payers sort of on the ground. While I think the policymaker view is more helpful to have that percent spend to say, okay, we're not making the pie bigger, we're just moving around how big the slices are. So I would recommend that regardless of how OHCA decides to set the benchmark, that they continue to measure both so that both types of stakeholders have the view of the data that I think is most relevant for their needs.
Thanks. That's really helpful. I think Jeff has a comment about operationalizing, and I'm aware that at least my instinct is to say, oh, let's do both things. These questions, and so I want to be careful there too. So curious to hear from the plan folks. Thanks.
Well, I can just weigh in on that. It's super easy. We actually always do both. The PMPM is, as long as you have a number of member months, which is something that's collected by OHCA, doing the PMPM is just a simple division. And so there's no reason that you couldn't. The difference is for the PMPM, you take the total spending and that's your numerator, and the denominator is your number of member months. For the total medical expense, you take the total spending and your denominator is total spending.
With PMPM in that sense, sorry, just to jump in real quick, is there any attempt to remove outliers on a PMPM calculation? Is there any, I'm just trying to think about how that works, if there's any context that might make it a little more complicated than just that simple division.
Really, really great point, really interesting point. I have not encountered that yet with states on the behavioral health side, but we do encounter that sometimes on the primary care side. So for example, in our work in Delaware, where there's a requirement of spend on primary care, the commissioner is currently considering how to handle some outlier cases.
Carrie, it looks like your hand is raised. Go ahead.
Yeah, hi. Not sure I have much really to add to this discussion, but I just want to appreciate the complexity and the nuances here. And I given what we know and what we don't know, I think it does make sense to, and I appreciate Mary Jo, you're kind of explaining that the PMPM and also the total medical expense. It does seem like it would be helpful to chart both, so we can see, how spending is perhaps thinking about investing per person, but then also how it's increasing the slice of the pie. It does seem to me like the fact that in the commercial market, we're not capturing the entire network of providers, and individuals are not getting, they may get one visit, but they're not getting all, a full set of visits after they see a provider. That really the only way to, or an important way to improve that is really looking at that PMPM and thinking about expanding that investment, which then allows for more a full, complete care plan for individuals, as opposed to that one and done approach, which I think is what we're trying to move away from. So really appreciate that, and appreciate the general attempt to try to align with the primary care benchmark to the extent that we can, just so we can see what's happening. Also, just, I guess the question is, and this isn't necessarily a specific recommendation on timeline, but as we're thinking about the timeline, how are we also looking at the interactions between what's happening in the primary care spend and then that behavioral health spending benchmark? So regardless of what that timeline is, it does seem to me like having an opportunity to kind of look at the interaction in kind of shorter term intervals to see how those are progressing, and maybe think about any tweaks or changes could be useful. Thanks. I hope this was helpful, but just pulling thoughts together here, and appreciate the discussion.
Thank you, Carrie. Yeah, really appreciate it. So I think it sounds like folks are really interested in measuring both per member per month behavioral health spending and percent of total medical expense. And then just based on the survey results that folks responded to, and we heard some general preference from the advisory committee members to focus the benchmark on a per member per month amount. Are there any, do folks have any like major concerns with structuring the benchmark around a per member per month amount? Just to pose a specific question there. And maybe Robbie, do you want to jump in?
Yeah, and just a follow up to my previous one, probably for Mary Jo, because we've been thinking a lot about like the baseline report, right, which like is pretty focused on PMPY. What could you explain more around rationale behind like setting up PMPM for a benchmark for behavioral health versus PMPY, and like the perceived benefits or risks of either approach?
Sure. I think it could be either way. I don't think that there's going to be a big difference. It's really just whether or not you express the member months as a culmination of 12 member months per person or one. So really no difference there. I think if it's more intuitive to stakeholders to have it be a PMPY, that's fine. It can be a PMPY.
Okay, no, thank you for that. That's helpful. I'll bring that back to the team and we can provide some further input.
That'd be great. Thank you.
Stephanie, yes, go ahead.
Hi, this is Stephanie Berry with Anthem. I just wanted to say that we had only said we wanted TME just to be in line with the existing primary care work. So I'll need to take this back to kind of understand the differences in that as well.
Okay, thank you, Stephanie. Yes, would love some additional feedback. Any other kind of questions or concerns about potentially moving forward with a structure either based on a per member per month or a per member per year structure for the behavioral health investment benchmark? Okay, I'm not seeing any other hands raised, but if folks have hands raised, just jump in. I think just wanted to prompt folks for another question here. Do folks have any suggestions about a time frame for achieving the benchmark? Potentially, a shorter time frame to align with the timeline for the spending growth targets, a longer timeline to align with the alternative payment model and primary care investment benchmark, or something in between or other? Yes, Stephanie.
I think we would prefer to align with the already set alternative payment model goals and primary care investment benchmark, just to keep that consistent. And the fact that we're not even going to start collecting or starting this benchmark until next year potentially. So just giving more time for that.
Okay. Beth,
Yeah, just agreeing with that. Two points. There's a lot to do in this area, so I think the longer time frame is appropriate in acknowledging that. I do also think that as we get better data and, for example, bring in the outside the planned spending, for example, county behavioral health, as well as more of the Medi-Cal data, that we're going to have to come back and relook and rethink some of this. I mean, whereas the primary care one, the question's going to be, are we making the progress we should be making towards that? And if not, why not? On this one, it may turn out, however we land, that further information will precipitate revisiting the benchmark or how it's structured. Just because there's so much unknown and so much uncertainty here. Thanks.
Thank you, Beth. Yeah, it's a really important consideration that the longer timeline, the 2034 timeline, setting a benchmark there means we might need to adjust along the way. I mean, we noted that for primary care that we might adjust along the way, but I think even more for behavioral health, that if we had a longer timeline, we would likely need to adjust as we learn more. Amy, go ahead.
So I agree with those comments, and I think the more we can align with primary care, I think it'll help with the success of us, truly getting to goal and for the adoption of these changes, and to allow for the nuances, right, as we change. So I think aligning as much as we can with primary care model, because that's, and also the APM model, of course.
Great. Thanks, Amy. Yes, Monica.
This may be overly ambitious and optimistic, but I think if we agree that some portion of outpatient behavioral health really could and should be managed in the primary care space, could it be that if we resourced up primary care first, got closer to our goals, that then the PMPM required for behavioral health is actually lower? So if we're doing them at the same time, right, you kind of can't tell. We're just sort of saying more and more on both. But is it actually more and more in both, or is it actually more in primary care, follow the evidence, and then let's see at a slower time frame or a pushed out time frame how much ramp up you need for behavioral health? I guess I'm wondering about the interplay between the two, and might it make sense to stagger?
Thanks, Monica. That's an interesting consideration. So I'm thinking in terms of like a staggered, rather than maybe shorter annual improvement goals, we have maybe a few longer interim goals leading up to a 2034 goal for behavioral health or something to that effect.
Yes, yeah, exactly. Like maybe yeah. And then of course we restate, we'll have more information, we'll see where we are with primary care. Like if we magically got to 15% for primary care at a faster timeline, would we all feel the same way about needing the same level of investment and speed in the behavioral health space? Or would we feel like we're meeting our needs, the needs of the population, through enhancements in primary care? Because like you said, the balloon's not supposed to get bigger, right? We're trying to have the balloon be smaller.
Mm-hmm. Yeah, Mary Jo, go ahead.
I think that's such an interesting point. And one piece that I think plays into this is that the portion of spending that is both that is behavioral health and primary care will be counted towards both benchmarks. And so why I think that is helpful is that if that portion of the pie, that integrated behavioral health slice of the pie, is growing, it will be credited towards both increases in primary care and increases in behavioral health. And so hopefully we do see that portion of the pie grow, because it is so critically important to the access folks need. But just wanted to flag that on the measurement approach.
I think I think that makes sense. That what we've discussed is, if I'm tracking the things we've discussed that would overlap, my sense is that it's going to be a small percentage of the overall behavioral health spend. Like it's going to be, I don't know, 10%, 5%, some exceedingly small percent. But just to throw that out there, because I think it's primarily the screenings that we're talking about, trying to tease apart, and maybe there's a few other buckets, but it'll be pretty minimal.
It also would include primary care visits with a primary care physician where a behavioral health diagnosis is listed as
That's
the
right.
primary diagnosis. So we realize
That's
that
right.
current billing practices don't prioritize putting behavioral health as the primary diagnosis, even when it in fact is, but they are captured if that diagnosis is listed first.
Yeah, so that'll bump it up a little bit. I still think it's going to be generally the overlap's going to be pretty minimal. Just the medicalization of, as you said, the lack of focus sometimes on behavioral health. But maybe that'll change. Who knows?
So I think we've had like a really great discussion. So it sounds like there's lots of things for the OHCA team to consider. It seems like there's general interest in focusing on a per member per month or per member per year amount for the benchmark, a longer term goal of achieving the benchmark, but with some spaced out intermediate milestones. And so it seems like that's where folks are landing. But of course, welcome any feedback. I think a few folks noted that they would want to take this back and bring back feedback. So feel free to follow up afterwards via email or a meeting with additional feedback. And Hector, go ahead.
Hi, this is Hector with Help. Thank you, Margareta. I'll just say that I agree with most of the discussion, but I do feel a little bit hesitant to jump in the mindset of longer term improvement, given the urgency I feel to make sure that plans are making improvements. So I would, if that's the way we decide to go, I think it's important to make sure that we are evaluating on a periodic basis in between, making sure that there are improvements. And part of my reasoning for that is that I think a lot of these services that we are including in the benchmark are services that plans should be covering already. So the infrastructure should be in place, or it should be starting to get in place already, right? So of course, there's things that should be done, and plans will need to work on before rolling out expanding a lot of these services. But I think the at least in terms of the coverage requirements, a lot of those have been in place or are in place now. And I think it's important to track that plans are making those improvements and are actually spending on that sooner rather than later. So just I wouldn't say I'm totally in favor of just doing the annual tracking or target, but I think definitely at least some way to evaluate and track where how they are improving without having to wait until the end of the timeline.
Thanks, Hector. Yes, we agree. So despite how long we set the benchmark, OHCA would be reporting annually on progress towards the benchmark in our annual reports. So even if like the kind of benchmark milestones are maybe 2 to 3 years out leading up to a 10-year goal, we would still report annually progress towards the benchmark in OHCA's annual reports. Okay, so I know we have 2 more agenda items to get through, and it's okay if we don't get through them all today. And we can our last agenda item is focused on the claims-based code set. So we plan to send that out to you all. So if we don't get there, we can at least do kind of a quick preview of what's in the code set and what you'll be receiving later this week. So I'll turn it to Mary Jo to walk us through the behavioral health non-claims payment measurements and some progress we've made there.
Excellent. Thank you, Margaretta. And the good news is a lot of this is going to be a refresh from last month with just a couple of updates. So I'm now going to turn to those remaining issues that we need to resolve regarding measuring non-claims behavioral health spending. So as I mentioned, most of this is a review of what we discussed last month, but there were a few unresolved questions about how to allocate certain subcategories of non-claim spending to behavioral health. So as a reminder, these are the expanded framework categories for grouping the various types of non-claims payment. In Category A, population health and practice infrastructure payments, the payments for subcategories A1 and A3 would be considered behavioral health spending if and only if they are made to behavioral health providers and provider organizations. Where we made some adjustments is around payments under subcategory A3, social integration, and we're going to look at those in just a few minutes. All subcategory A2 payments for primary care and behavioral health integration would be included in the behavioral health and primary care module as part of behavioral health spend. And then spending in subcategories A4 and A5 would be limited to a maximum allowable amount. A new recommendation is that the limit be equal to the portion of total claims and capitation payments that are going towards behavioral health. In other words, the amount of practice transformation and infrastructure payments attributed to behavioral health would reflect the proportion of spending for behavioral health in claims and capitation payments. And we're going to look at this more closely in just a couple minutes. For Category B, performance payments, those would be recognized as behavioral health care payments when they are made to behavioral health providers. This slide has not changed from our previous discussion. Condition-related, episode-based payments would be included in measurement of behavioral health spending if the episode of care is behavioral health related. We are not aware of any existing or planned procedure-related episode payments for behavioral health, nor are we aware of any health plan arrangements with behavioral health practices agreeing to take on risk for total cost of care. For behavioral health capitation payments, subcategory D4, 100% of the payment would be included in behavioral health spend measurement. For more general types of capitation, professional and global, and payments to integrated comprehensive systems, the behavioral health portion would be allocated using the formula we used to allocate capitation payments to primary care, which we reviewed last month. And as with primary care, facility capitation payments would not have a portion allocated to behavioral health spending. Payments in Category E, other non-claims payments, would be limited to a maximum level using the same proportional method recommended for infrastructure and practice transformation payments in subcategories A4 and A5. And again, we're going to look at that in more detail in just a minute. But first, we wanted to show you this slide, which we have updated based on the work group's last meeting. So to review, the diagram shows different ways that a health plan might make social care integration payments. The icon labeled clinical represents payments to behavioral health practices for any social needs, screening, and referrals that they do. OHCA's recommendation is that this type of payment would be included in non-claims behavioral health measurement. The two icons at the right, connectors and plan staff, OHCA is suggesting that those payments would not be included. An example of the first type of payment is one where the health plan pays a third-party vendor for information and referral to services. Similarly, internal spending for health plan staff to connect members to services would not be considered a payment for clinical services. OHCA is now recommending that the subclinical category should be included in social care integration payments. These are payments that health plans make to professionals such as peer support specialists for the assistance that they provide members in connecting to and navigating behavioral health related clinical and social services. Input from the work group at the last month's meeting helped us to frame up this recommendation. As I mentioned, we're going to go into a little bit more detail here on that formula for determining the maximum amount of non-claims payments that are allocated to behavioral health care for certain non-claims categories. So this is an example using subcategory A4, practice transformation payments, but the same approach would apply to subcategory A5, which are information technology infrastructure payments, and to category E, which are other non-claims payments. The formula shows that the behavioral health spend for subcategory A4 equals the product of all practice transformation payments and the ratio of behavioral health claims and capitation payments to total claims and capitation and other full risk payments. In other words, if, for example, behavioral health claims and capitation are 6% of total claims and capitation payments, then the most that a payer could allocate from subcategory A4 to behavioral health would also be 6%. Now we're going to pause and have some discussion. We'd like to get your feedback on these updates to the non-claims measurement methodology and any other comments that you have on the methodology generally. And I'll turn it over to Margaretta for our discussion.
Thank you, Mary Jo. And I'll just open it up for discussion. Anybody want to weigh in on these questions and the proposed approaches based on the discussions we've had in the last few months?
One question on slide 28 on the connectors. Realize this is like teasing things apart, which is so hard. So I understand some why we might exclude the referrals themselves or the referral process. I feel like I'm struggling a little bit more with information. I think what you're talking about is things like maybe connecting an EHR to community information exchange, a CIE, as opposed to an HIE. Is that kind of what you're referring there to like a third party? Can you, okay, maybe give examples of what we're talking about when we say third party vendor for information before I make a comment.
Mary Jo, do you want to jump in there? Or
Sure. I think of that as more like newsletters or here's some tips and strategies, not sort of technology information.
Okay, then I'll pull my comment back because it was more on technology interoperability.
And I think, Jeff, for like technology and interoperability, that would be captured under A5, the
Okay,
EHR,
that makes sense.
HIP infrastructure pieces.
Okay, that makes sense.
Thanks, Mary Jo. Beth, go ahead.
Yeah, back on that slide 28, I think for me, what threw me off a little bit there was the reference under connectors to clinical services. And I think I understood the answer to the question, but it's one thing if it's in the line between social services and clinical services appropriately is should be blurry, and we should have more of the social services to support people's health. So don't hear this the wrong way. It's just, it's because it says behavioral health clinical services. That's why it raised a little question for me, but I'm not an expert in this area, so I defer. Thank you.
Yeah, and Mary Jo, correct me if I'm wrong, but here I think what we're emphasizing is that we're the referral or the payment related to a referral or information related to behavioral health or social services would not count under this category, whereas on the left side, the clinical, all of those payments for clinical services would count. So it's just a little bit of that information and referral piece that would not count.
So it may just be the way you've summarized it rather than what you're actually counting.
Okay, we can work on that.
Which is always the challenge. I understand.
And I'll say the word connector, like when you use that word, most people in informatics spaces are going to think of like data exchange, interoperability, HIEs, CIEs. So I don't know, maybe Beth, that's part of like that's where my mind goes. So just
Okay.
FYI.
Thanks, Jeff. Yeah. It's always a process to explain these complicated pieces, so appreciate the thoughts and the feedback. Okay. Any other thoughts about the allocation approach for subcategories A4 and A5, which are practice transformation and those HIT infrastructure payments, or the other category? Okay. Yeah.
So actually, let me just make sure I'm fully tracking. If we compare, just to go through it again, to compare and contrast A1 through 3 versus A4 and A5. So A4 and 5, you went through in detail, you showed like a methodology that makes sense. So A1 through 3, to say it again, so payments to behavioral health providers. And I think I'm struggling a little with the Boolean logic here in the second half of it. And provider organizations for care management coordination. So provider organizations that are doing care management and care coordination. Is it three different buckets? I think I'm just struggling like with the ordering of those three. The first makes total sense.
Sure. So how I think of it is include payments to behavioral health providers and behavioral health provider organizations who are doing care management or integrating primary care and social care with behavioral health.
Got it. So maybe just put like I know this is like this is again just explaining the concept. Maybe put like number 1 and number 2 so it's clear that they're two distinct buckets, and then add behavioral health before provider organization. I was just struggling to understand the context of the first. Again, was very clear. It's the second I was struggling with.
That's really helpful, Jeff. We can make those updates.
Great, thank you. Any other questions or comments? Okay, Then we'll do, in our last about 15 minutes or so, we'll do a quick run through of our claims-based behavioral health spending measurement. And I think the key here is we just want to walk you through and preview for you the code set that you'll be receiving and kind of some key questions we are hoping to get your feedback on. So I'll turn it over to Debbie.
Thanks, Margaretta. So I will overview the code set that you'll be reviewing soon. And here's the list of the contents of the code set. So OHCA is developing the detailed set of codes that data submitters will use to identify behavioral health claims. And as we've mentioned, we'll be sending out that draft code set later this week for your review. And we will share some specific questions that we have for you later in just a few minutes. So the code set is an Excel workbook with a separate tab for each of the bullets that are on this slide. So the list of diagnosis, service, care setting, and national drug codes that define a behavioral health claim are listed in their respective tabs. Another tab groups the service and care setting codes into service subcategories. And then the primary care taxonomies tab identifies primary care providers under the existing primary care definition and also includes the additional taxonomies that may be added to capture that integrated behavioral health in primary care. So once it's finalized, that final code set will be sent out to the data submitters along with a detailed step-by-step set of technical specifications for implementing it when they submit their data to OHCA. So these are the steps OHCA has taken to produce that draft code set that you'll be reviewing. We started with the specifications from the Milbank report, which were developed with input from an advisory group of state behavioral health leaders and subject matter experts, including payers. And then to tailor the definition to California's needs, OHCA reviewed the Department of Managed Healthcare's covered services and Medi-Cal's code sets and consulted with those agencies. And we're now at the third step in this process, circulating the draft code set to the work group for your review and feedback. So for a little bit more detail here on this slide, the process OHCA has followed in developing the code set was designed to take advantage of the foundation created by the experts who contributed to the Milbank report and to build on that foundation by engaging California stakeholders and refining the code set with California-specific details. So the Medi-Cal code sets that were used to refine OHCA's code set included DHCS's specialty and non-specialty mental health service codes, drug Medi-Cal substance use disorder service codes, and codes used by the Children and Youth Behavioral Health Initiative. As we've discussed in prior meetings, OHCA also expanded the primary care provider list to capture integrated behavioral health services in the behavioral health in primary care module. And OHCA has consulted with the work group and other stakeholders to group the service and care setting codes into reporting categories. And here, once again, is the overall approach to using the code sets to measure claims-based behavioral health spending. So for most medical claims, behavioral health care is identified by the primary diagnosis code on the claim. A broad list of behavioral health services may be delivered by any type of provider as long as that primary diagnosis is for behavioral health. The exception to the primary diagnosis requirement is for behavioral health screenings and assessments, which are considered behavioral health care regardless of diagnosis. So when screenings and assessments are done in a primary care setting by a primary care provider, they'll be included in the behavioral health and primary care module. And integrated behavioral health services will also be included in that module with the expansion of the primary care provider list to include certain behavioral health professionals. And finally, for pharmacy claims, a list of national drug codes to identify behavioral health pharmaceutical treatments has been compiled. So these are some questions that we encourage you all to consider when you're reviewing the draft code sets. There are a lot of codes in there, and we would like to have your views on any of the codes as they stand now and any that you think should be added or removed. And we ask that you pay particular attention to the addition of the certain behavioral health providers who provide integrated behavioral health services in primary care settings. For the service codes, we'd like to know your ideas about screening and assessment codes that should either be included or excluded. And for diagnosis, we're especially interested in your thoughts about the Z codes that are in the current draft code set. So you'll receive these code sets within the next few days, and we'll include these questions as well as further instructions for how to give your feedback when we send those out. And so now I'll pause to see if any of you have questions about the code set development and the process for your review. And I see first up, Jeff.
Thank you so much. So per Christina's earlier comment in the chat, just thinking about where there is overlap between primary care and behavioral health spend, she obviously included CCM, primary care, behavioral health models, a variety of different models. I'm curious, I don't know, I'm not an expert in coding in those particular spaces, and I'm curious if that came up to try to be concrete about including any codes relevant to those models. I think in some cases there's just no way to capture it, like collaborative care model, for instance, when the primary care visit occurs, unless they put the BH ICD-10 code first, you're not going to capture that. But I'm wondering about when the, let's say, psychiatrist time in that model is billable under a contract. Do codes even exist for that? Has that come up, trying to capture these different, more, I won't even call them innovative models, because CCM isn't really innovative at this point. There's lots of evidence for it. So anyway, I'll put it there. I think you all get the point.
Yeah, and I can start and invite Mary Jo or Christina to add to that. So we have reviewed codes that are commonly used in both the collaborative care model and the primary care behavioral health model, and tried to capture as many of those as we can, while also being mindful that we don't have a way of knowing for sure if we have a behavioral health provider that a service like extended duration psychotherapy, for example, is being provided in an integrated setting versus a non-integrated setting. So we've tried to strike a balance in our draft code set for capturing as many of those services as possible without dramatically expanding the number of services that we would capture that really aren't integrated. And we welcome feedback from all who are expert in integrated care, and we've had actually several stakeholder meetings to try to maximize our capture of integrated care. Thank you for that question. Kevin.
Yeah, hi, thanks. And this always risks getting way down in the weeds and all these types of coding questions. And like Jeff, I have some sense, but not a great sense of all the codes and how they play out. But I mean, maybe if you go back to 35, Debbie, do you mind just, I think this, because so the primary behavioral, like in primary care, for example, I'll just give you an example. I think there is a specific claim, CPT code you use, for example, for a child when you do ACEs screening, right? That gives you a payment. Plus, you will build the E&M code for the full visit. This would only then measure the payment for that ACEs screening component and not the whole visit in which ACEs was performed. Is that correct interpretation?
Go ahead, Mary Jo.
Yes, unless the underlying visit also had a primary behavioral health diagnosis.
Yeah.
So, for example, okay, so you're following.
Totally. So if it's preventive, routine, well-child visit, did ACEs screen, the payment for the well-child visit code would not be counted, but the payment in addition that was given for the ACEs screening, or maybe, I don't know if there's a PHQ screening that gets a separate payment for an adult or something. Okay, I just wanted to I think that's the right decision on those when you can tease them out. And then if it's a primary diagnosis of depression, anxiety, behavioral health, what have you, that whole visit then gets counted for the payment. And then on that behavioral health and primary care, the second check, I'm just, behavioral health professions, did we add that to our list of primary care providers for our primary care measurement taxonomy too, or is this just for the behavioral health taxonomy?
Yeah, go ahead, Mary Jo.
Debbie, do you want to take it here?
You'll probably do it better, so I'll start and you can add. So that's a great question, Kevin, and I think what we've determined is that the best way to maintain this mutually exclusive, collectively exhaustive measurement of the module, the primary care, behavioral health and primary care module, is to in fact add those providers to the primary care provider code taxonomy list. And so all services that they provide that are on the primary care services list and that are delivered in a primary care place of service would be included in both primary care and behavioral health.
I thought that was kind of my recollection. It's testing my medium-term memory to go back to all those decisions. But that sounds reasonable because it's with all those other stipulations that it's in the proper setting so that it's really capturing a clinical social worker service in a primary care office or clinic setting for that visit would count as primary care, which makes sense. Okay, thanks for the clarification.
Yeah, thank you. Go ahead, Vicki.
This may be also getting in the weeds, but I just want to make sure I understand it. One of the federal groups that I'm working on the ICD with in terms of social determinants of health, which are the Z code you're talking about, we actually track that between 9, 10, and 11, ICD 9, 10, and 11, that there are all these changes. So what's the period of the data and which you're using? Because if you're using any that will be ICD 10 and any that then are ICD 11, there are all these changes which I think people thought were subtle, but those of us in behavioral health would say changing those words actually change, what the actual treatment needs would be. So what boundaries are you crossing in terms of the ICD for your Z codes?
Right now, all of our codes are from ICD 10, and our first data collection will be in 2026 for years 2024 and 2025. I think clinical, service delivery years 2024 and 2025. And we're aware that ICD 11 is that we need to be continuing to be mindful of including ICD 11 codes as that rolls out.
Yeah, well, it's not including them. It's also making sure if you want to look over time that you kind of have a crosswalk. I mean, I think when we finish this paper, the intention is to publish it and it'll show you. So it actually give you the way in which to make a crosswalk.
Thank you. That'll be very helpful when you have it. Please do share. And go ahead, Beth.
Oh, I was just Vicki answered the question I had, because if we're actually looking through 2034, at some point we'll have to make the adjustment to the new ICD 11, and glad to hear that it's moving in what I think most of us agree is a good direction. So probably not as far as Vicki wants, if I've understood her correctly over the last few meetings, but thanks, appreciate the work. Thank you.
Thanks, Beth. And yeah, thanks, Vicki. And we do intend to at least review the code set annually as we are, collecting data annually. We may not need to make changes to the code set annually depending on what occurs, but we do intend to review the code set annually and make updates as needed. Yeah, Vicki, one more.
Yeah. just quickly, this is something to think about, and that is there will be a proposal going forward to think about for behavioral health coding in our electronic health records is to do it using kind of the RDoc format. So it will be not just signs and not just diagnosis, but signs and symptoms, because that actually is the pathway to some extent of improving pharmacologic interventions. So I'm just saying, given that you have this, look going forward, we're working on that now as well.
Yeah, that'll be super helpful. Thanks, Vicki. I know we're over time, so thank you everyone for the wonderful discussion today. We made a lot of progress, so we're excited for our work group meeting in May. So just as a preview, we are hoping to bring some data to you all and then some draft recommendations for the behavioral health benchmark, and just think through the implications of the benchmark. So thank you everyone for your participation and discussion today. And as always, please feel free to reach out and send us additional feedback, or we're happy to meet as well in between now and May. So thank you all. Have a great day.